here we need to really utilize this whole cancer immunity cycle which you have in front of you in order to achieve optimal integration of the immune system and cancers. Now, this cancer immunity cycle starts at the left bottom corner with what I would describe as release of cancer cell antigens. They are really required to jumpstart the process of the immune system tackling cancers. How are cancer cell antigens released? Well, it can happen spontaneously with cancers, but it also happens with any effective cancer therapy, maybe radiotherapy, chemotherapy, or any other targeted treatment. These cancer cell antigens are now taken up in antigen-presenting cells, leads to priming and activation of immune cells that have to travel back into the tumor, infiltrate the tumor, where they recognize the cancer cells through the T cell receptor and ultimately can kill cancer cells. Now, the question to you is, where do immune checkpoint inhibitors work in this cancer immunity cycle? And the answer is pretty much in the periphery when it comes to the final step to killing of cancer cells. But you can imagine if all the other steps don't work, the best checkpoint inhibitors is probably not going to give patients a benefit. So in a very simplistic way, there are three things we need to make immune therapy work. On the right side, you see we need immune targets, or so-called neoantigens. Antigens are proteins that are different in their structure from normal proteins and are therefore not tolerated by the immune system. Where do those proteins come from? There's a clear link between mutations. It's difficult to have a neoantigen without a mutation. However, not every mutation will lead to a changed protein, and therefore the link is not linear. It's not the more mutations have, that automatically you will respond to immune therapy. It is about the number, but equally important is also about the type and the quality of mutations. The second or third factor on the left of the slide is an active immune system we need, and that has two main factors to it. One is the cellular component, which is here abbreviated with TILs, tumor-infiltrating lymphocytes, but you will all agree it goes way beyond this. There's a whole range of positive, but also negative immune cells that can be in a cancer, promoting or suppressing an immune response. And what is really important is to see the numbers, the proportions of these cell types, and also the spatial interaction of them in order to see whether we have a good cellular component of the immune system in the cancer. The final point is whether those immune cells are switched on or switched off. And the body normally regulates the immune system very tightly, switching off the immune activation as soon as it's no longer required by using so-called inhibitors or activators to switch it on the first instance. And again, the question back to you is, where does immune therapy in terms of checkpoint inhibitors work? And the answer is really in what you see in red here, addressing those checkpoints and overcoming that if the tumor has actively switched that on. But you can imagine the best checkpoint inhibitor is not going to work if you haven't got immune cells there and if you haven't got any targets in terms of neoantigens. There's a huge debate around the role of PD-L1, which is obviously part of the treatment target for those checkpoint inhibitors targeted PD-1 or PD-L1. And there are different ways how we can measure PD-L1, and I won't bore you with all the details, but we can look at either tumor cells or immune cells or a combination of both, as we do with the CPS assay. We can also count those cells in different ways by either counting positive cells or looking at a certain area and see whether it's occupied by positive immune cells. And there are different cutoffs. And for breast cancer, we use 1 and 10, not 20 or 50 that are used for example, in lung cancer. There are at the moment two main antibodies we need to talk about. One is SP142, the other one is 22C3. SP142 used in the atezolizumab study, 22C3 in the pembrolizumab study. And I think that's really important because the groups, those antibodies describe very different populations. What is there to know about PD-L1 in triple-negative breast cancer? The first thing is that most of the PD-L1 expression in triple-negative breast cancer is seen on immune cells, not on tumor cells. If you use the SP142 assay, 41% of patients have PD-L1 positive immune cells, but only 9% PD-L1 positive tumor cells. And the SP142 assay considers practically all these patients by looking at positive immune cells. But I already mentioned those different assays are very different and not completely overlapping. If you look at the second antibody, 22C3, using the CPS scoring system, not just looking at immune cells, but also tumor cells, with a cutoff of 1, and the cutoff of 1 was what we used for SP1 for 2. You will see with CPS, it's 80% positive. If you overlap this with SP1 for 2 with 1%, it's only 41% positive, a subgroup of the largely of the 22C3 patients. But if you use different cutoffs for the CPS assay and use a cutoff of 10, we come again to a subgroup of around 40%, but that's only incompletely overlapping with SP1 for 2. So in other words, there's no perfect assay that describes all patients who may benefit, but what we've seen is patients need to either have a CPS 10 assay, which is about 40% of patients, or as SP1 for 2 with 1% to see a benefit with immune therapy. And as those two assays are not 100% overlapping, in some cases, it may make sense to do both assays. Is there any single agent activity with immune checkpoint inhibitor in triple-negative breast cancer? Well, initially that was doubted, but when we did the trials, we were very pleased to see that activity. And there are 3 things we can learn from those very first studies. The first thing is there's single agent activity, and there was up to 25% in patients who had no prior therapy. So clearly encouraging single agent activity with atezolizumab or pembrolizumab. But the second learning was, and that came a bit of a surprise to me, is if you give immune therapy as a second or third or fourth line treatment, the response rates are markedly, I would almost say dramatically lower compared to the first line setting. And they dropped from around 25% to around 5%. You may ask, why is this? Because the genetic instability would suggest we have even more neoantigens available. However, what we didn't take into consideration is that over time, the stroma becomes more and more immune suppressive, and immune cells become more exhausted. So if you want to give immune therapy, try to give it as early as possible, because it may not work as well in later lines of therapy. The third learning we had from the single agent studies that patients who do respond often have a transformative benefit. And for example, the median duration of response with atezolizumab was 21 months in our trial. And it wasn't surprising that patients who responded in green had a long survival compared to patients who had stable disease in blue or had a partial response had progressive disease in red. And so all of that was the basis for a phase 3 trial that was designed, but it was a second and third line trial of single agent immune therapy, comparing it with chemotherapy, capecitabine, eribulin, gemcitabine, or vinorelbine. And with everything we just discussed, with knowing that the response rate in an unselected group of patients in a second or third line will only be around 5%, do you think it is realistic with our knowledge these days that immune therapy is better than chemotherapy single agent in an unselected group of patients? And the answer is probably not. And as a result, we also amended the study design whilst the study was maturing to not just look at overall survival in all patients, but also overall survival in patients with low PD-L1 expression with a CPS of 1 or higher PD-L1 expression with a CPS of 10. And you have seen the results. Essentially, the trial is negative in terms of overall survival. But if you look at the curves, you can see clearly immune therapy is not better than standard chemotherapy, but it also doesn't seem to be worse than standard chemotherapy in this setting. And when you look down to patients with CPS 10 with higher PD-L1 expression, there's maybe some early signal that immune therapy may do slightly better. And as a result, we did an exploratory analysis, which was not pre-planned, to look at patients who have very high PD-L1 scores, CPS 20. And here you can clearly see an interesting hypothesis being generated that patients who have very immunogenic tumors may possibly do better with immune therapy, even in a pre-treated setting. And if you look at this in a little bit more detail, as you can see on the left, if you go from the higher groups down to, from ITT down to CPS 10 or 20, the number of TILs increase, the tumors become more immunogenic, but the subgroup becomes smaller and smaller, and CPS20 is only about 70% of patients. But what is interesting, the response rates go up, 26% in CPS20 group, and those patients clearly seem to have a survival signal. So there is still an ongoing discussion whether this small group of patients with very inflamed tumors may be candidates for single agent therapy, but the majority of patients should be considered for combination therapy. Now, when we look at combinations, it's worthwhile going back to the cancer immunity cycle which we started with. And we've already looked at where PD-1 targeting drugs work. But what would be sensible combinations? Well, in my opinion, the most sensible combinations are combinations that tackle the cancer immunity cycle at different ends. Chemotherapy is the first generation, and it really starts at the beginning of the process of the cancer immunity cycle, releasing cancer cell antigens, reducing the activity of regulatory T cells, which are a negative regulator in this process, increasing PD-1 expression, increasing CD8 expression, clearly having synergistic activity. But you may be aware that there are other combinations being explored with novel targeted agents, with CIT combinations, and in the future also with antibody drug conjugates. Now, we've already looked at this slide very briefly, the two first phase 3 trials that read out, both very similar, both first line, both chemotherapy with and without checkpoint inhibitor. There are 2 or 3 small differences between the trials. Impassion 130, which was the first trial, used nab-paclitaxel as a backbone. Why not? The only taxane we could use at that time that could routinely be given without steroids, and we were worried about the impact steroids could have. We also used the SP142 assay for stratifying patients. And if you look on the right side with the Keynote 355 trial, it gave patients a choice between different chemo, nab-paclitaxel as well, but also paclitaxel or gemcitabine carboplatin. Because of platinum being allowed in the control arm, we also allow patients with shorter disease-free intervals, 6 to 12 months, to be enrolled, whereas Impassion 130 only had patients with at least 12 months disease-free interval in there. And the biomarker assay on the right side in Keynote 355 was the CPS assay as discussed. Co-primary endpoints, progression-free survival and overall survival. Study populations very, very similar, as are the results. PD-1 positive patients, similar hazard ratio 0.62 with atezolizumab, 0.65 with pembrolizumab, clearly very similar, very comparable results, but only in PD-1 positive patients benefit seen. If you look at PD-1 negative patients, progression-free survival, you can see clearly no benefit there, and therefore we should limit these treatments outside trials only to patients with PD-1 positive tumors. What about overall survival? Again, only looking at patients with PD-1 positive tumors, we see clearly an improvement in survival, hazard ratio 0.67, median now for the first time more than 2 years, 25 months, 7.5 months difference, and added benefit of immune therapy, and possibly an early indication of a tail of the curve with a third of patients being alive after 3 years. Now, can we choose different chemotherapy backbones? And I would put a big caveat behind this based on the results of the Impassion 131, the third phase 3 trial that was recently presented at ESMO. And this is similar to Impassion 130, but has 2 or 3 major differences. The first one is it uses paclitaxel rather than nab-paclitaxel. And that is important because all patients required dexamethasone, at least for the first two infusions. It is a smaller study, only 650 patients, 2-to-1 randomized. And that means the control arm is getting very, very small. And when you look at the results, you will see what I mean, because that has an important implication. Why am I going on about this? Because the trial is ultimately negative. If you look on the right side, progression-free survival in patients who are PD-1 positive, it's overlapping in the first 6 months, and only then we see a separation of the curves, but that is not significant. And we also see no benefit in overall survival in this trial. But what is really unusual here is that the control arm, which received paclitaxel alone, had a survival of 28 months, which is completely unheard of in triple-negative breast cancer, such as this control arm, which is only around 100 patients, may have been subject to patient selection, and we all know how heterogeneous triple negative breast cancer can be. Now, looking more at the different chemotherapy regimens and going back to Keynote 355, which had 3 different chemotherapy regimens, do we see a clear difference? Well, the answer is probably not. If you look at the forest plots here, taxanes seem to be doing similarly well to gemcitabine and carboplatin, as do early relapses compared to late relapses. And we looked into this a bit more detail at San Antonio with updated results, where you can see very clearly patients with paclitaxel, although it's a very small group, seem to do similarly well as patients with nab-paclitaxel. What is important to mention is that these are not randomized data between the different chemotherapy regimens. And in fact, there has been selection bias in the choice of chemotherapy regimens. If you look, for example, at the bottom of the slide, on the right side, the different chemotherapy regimens chosen depending on how long the disease-free interval was. And in orange, you see gem-carbo, and it's very obvious that early relapses predominantly receive platinum-based therapy, nearly 80%, whereas in later relapses, only half of the patients receive gem-carbo. So that needs to be considered when we look at the platinum-based data. But overall, these results are encouraging and reassuring that taxanes may still work. Where are we going from here? One of the questions for us is, can we tailor immune therapy a little bit better? Is there a way for personalized immune therapy? We have discussed that some patients have a lot of immune cells and therefore have pre-existing immunity, inflamed or hot tumors. Other patients have these immune cells just hovering around the cancer, and we need to find ways of bringing them in, whereas a third group of patients have practically no immune cells. And it is clear that we need to think about applying different strategies to these situations. For inflamed tumors, with a new standard of care, chemotherapy and immune therapy in the first-line setting. For patients with excluded immunity, we're trying to bring those T cells in, looking at combinations, for example, with their VEGF-targeted drugs, but also other combinations I can talk about in a second. And for cold tumors, we're trying to generate T cells, and this can be through an effective cancer therapy, neoantigen expression, cell-based therapy, possibly vaccination strategies. How are we going to test for all these strategies? Well, one way is to use preoperative platforms, and we have a platform ongoing where we give us a window trial, 2 or 3 weeks of immune therapy prior to surgery, and look at all those different combinations, and then see how they change the immune composition of cancers, which allows us to hopefully select or deselect treatments very effectively going forward. These are linked with metastatic breast cancer studies, and there are 2 large platform trials, I would describe them as looking into different combinations of immune therapy with other drugs. And Begonia and Morpheus have already reported some of their data. What is really encouraging, in my opinion, is in particular the combinations of new antibody drug conjugates, DSA201, DS1062, or sagituzumab, and then in the Morpheus platform. And just to show you what we might be able to see in the future, data just from ASCO last week with DSA201, HER2 targeting, but this is given in HER2 low patients. So patients predominantly with IHC1 plus, a few with IHC2 plus, triple negative cancers otherwise. Irrespective of PD-L1 expression, as you can see, most of those patients in fact were PD-L1 negative. And you can see in this small cohort of patients, first line, substantial activity, chemo-free, DSA201 targeting HER2, durvalumab targeting PD-L1, impressive combinations, and we will explore this further going forward. So in summary, we have seen durable responses with single agent immune therapy target PD-1 or PD-L1 and a substantial overall survival in these patients. We seem to be seeing better responses in earlier lines of therapy, and the phase 3 in pretreated patients was negative. Unfortunately, biomarkers are not great to reliably predict responders, but a high CPS score identifies inflamed cancers and may be used in the future. The standard of care is now a combination of chemotherapy and checkpoint inhibitors target PD-1 and PD-L1. Atezolizumab and nab-paclitaxel have improved PFS and overall survival in first-line setting. pembrolizumab plus taxanes or gem-carbo has improved PFS. In the first-line setting, we're still waiting for the OS data. The benefits is largely limited to PD-L1 positive tumors, and that's defined with the SP142 assay for Atezo or with the CPS10 assay for Pembro. I would still put a caveat out there around the use of paclitaxel, as paclitaxel and atezolizumab failed to improve PFS in a first-line study. And we earlier discussed the benefits of chemotherapy and immune therapy in early triple-negative breast cancer, which I'm very happy to address in the discussions. Thank you very much.
Thank you very much, Peter. So, Shadi, I think we'll have 1 or 2 questions max to save time. So we have 1 question for Dr. Schmid from the Zoom attendee. So mixing the Olympiad and CREATE-X studies, can we stop using adjuvant Xeloda with adjuvant olaparib for PRCA positive breast cancer with residual disease? So what is the recommended adjuvant treatment for these patients based on all of these trials?
It's a good question. So I think looking at the Olympia data for patients who met the criteria for the Olympia trial, i.e. patients who received neoadjuvant therapy and then had residual disease, or who have high-risk patients who have primary surgery, we should avoid, in my opinion, in those patients, and had adjuvant chemotherapy. I do think it is an excellent option, and in my opinion, the preferred option. So BRCA germline mutant patients, 1 or 2, who meet those criteria, I personally would recommend olaparib rather than capecitabine for that group of patients.
Excellent. So there is another question. So if possible, staining determines response, should we use it in breast cancer, breast case IO, and should we repeat the biopsy in subsequent lines, for example, neoadjuvant, adjuvant, or first line?
I'm not in, so if this is a question as of what tissue we are using, the answer is I would be fairly pragmatic. We use any tissue you can get hold of where you have a positive result. There are a few things to consider. You can't do the test on a bone biopsy. And if you do the test on a liver biopsy, it's most likely negative. Liver biopsies were only positive in 13% of patients compared to 40% of patients with other disease sites. So what I often do is I look at the primary tumor, I look at metastatic lesions, I test more than 1 lesion. So for example, I had a patient last week for a second opinion from the Marsden who had a biopsy taken of a recurrence in a lymph node. But when I asked her where that was exactly taken from, it was from within the radiotherapy field, and it came back as negative. Now we know that radiotherapy can sometimes create false negative data from a PD-L1 status. So I asked them to repeat it on the primary tumor, and it came back as PD-L1 positive for the patients now receiving immune therapy. So we need to be a little bit flexible there. The data from the trial suggests there's similar benefit whether it's taken from the primary tumor or from a metastatic site, and therefore I would always consider testing more than 1 side if it is negative, and if the patient obviously has time. What you want to avoid is testing for 6 weeks and the patient getting really unwell during that time.
Thank you, Peter. It was a privilege to have you with us in this event. Thank you very much. The mic is yours, Shadi, to present the next speaker.
Thank you, Dr. Fahad. Well, our next speaker is Dr. Mutabal Fahedi. So Dr. Fahedi, he will be discussing about the